All right. Shannon, can you hear me okay?
Yes.
All right. Good morning, everyone. Thank you for joining our Grand Rounds lecture. I'm Rahul, one of the General Cardiology Fellows at VCU. Today, I'm pleased to introduce to you our speaker, Dr. Barbara Lawson, our very own superstar interventional cardiologist at VCU. Dr. Lawson earned her undergraduate degree in Spanish and chemistry from the University of Virginia. She graduated with honors from the University of Texas Medical Branch at Galveston, where she was inducted into the Alpha Omega Alpha Honor Society and was also awarded the William Todd Midgate Award for Superior Clinical Practice. She did an internal medicine residency at the Johns Hopkins Hospital, her cardiology fellowship at the Cleveland Clinic, and subspecialty training in interventional and structural cardiology at Johns Hopkins. She joined the Pauley Heart Center in 2016 as an assistant professor and was promoted to associate professor in 2022. She's also employed by the Richmond VA Medical Center, where she provides veterans with high-level coronary and structural heart interventions. She serves as a program director for Interventional Cardiology Fellowship Program and the associate program director for the Cardiology Fellowship Program. She has received numerous awards for excellence in teaching. We are very grateful for Dr. Lawson's expertise on this topic and look forward to learning from her. At the end of the lecture, we will leave time for questions, so please submit your questions via the chat function on Zoom as they arise during the talk. We are also pleased to offer CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and at the end of the presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud.cme.com or contact Shannon Winston. I will now turn it over to Dr. Lawson.
Thank you, Rahul. And thank you guys for having me today. So today we'll talk about SCAD, or spontaneous coronary artery dissection, which is a different type of heart attack than we often see. The goals for today's discussion is to understand the patient factors that predispose to SCAD, to recognize the way in which it presents, to know how to manage it, and to identify the best treatment strategies for our patients following their SCAD event. So just starting with some definitions. Spontaneous coronary artery dissection is characterized by the spontaneous separation of coronary arterial walls by intramural hemorrhage leading to disruption of blood flow and myocardial infarction. The separation can occur between the intima and the media, or between the media and the adventitia. And I stress the fact that it has to result in myocardial infarction. These are not patients coming with stable angina and we incidentally find it. By definition, they are having myocardial damage. These events are non-iatrogenic, meaning not catheter related or not related to trauma, and the lesions are non-atherosclerotic. There are two mechanisms by which SCAD can occur. The medial hemorrhage hypothesis insinuates that there's a spontaneous rupture in the vasa vasorum, resulting in bleeding into the arterial wall, resulting in a false lumen that fills with intramural hematoma, resulting in separation of the arterial walls. Sometimes the increased pressure from the intramural hematoma can precipitate a rupture into the lumen, causing what we call a reverse intimal rupture. The second mechanism is the intimal tear hypothesis, in which there's a spontaneous intimal rupture, resulting in the false lumen filling with intramural hematoma and subsequent separation of the arterial wall. What we don't really know is the underlying biological event that triggers the intimal tear or the intramural hematoma. We know that tortuosity or coronary tortuosity is highly prevalent in SCAD, and that anatomy affects blood flow, just like anatomy of a hose affects how quickly the blood comes out of it, or the water comes out of it. And we therefore postulate that there's possible involvement of local hemodynamic forces in SCAD. Now, I am by no means an engineer, so bear with me as we go through this slide, but they looked at 13 patients with healed SCAD events, did 3D reconstruction of the affected vessels with morphometric analysis, with definition of local curvature and torsion in the vessels, as well as fluid dynamic simulations to derive time averaged wall shear stress and topological shear variation index. And what they found was that the vascular segments of healed SCAD are characterized by high curvature and torsion and high wall shear stress, likely reflecting increased local flow disturbances in those areas. So while this obviously needs more investigation, this is a very small study, it does suggest an interaction between the vessel anatomy and shear forces of the vessels in SCAD. The true prevalence of SCAD is unknown due to underdiagnosis. Early estimates are quite low because we had low index of suspicion in young, healthy women who are presenting with ACS and SCAD, who either didn't undergo angiography or they had angiography, but it wasn't pathognomonic for dissection. So the diagnosis was missed, or they were characterized as having mild atherosclerotic disease. In reality, the prevalence is probably less than 1% of all patients undergoing cath for acute MI, but accounts for 25 to 30% of acute MI cases in women under the age of 50, and about a quarter of acute MI cases during pregnancy and the peripartum period. The prevalence increases as age decreases, and up to 40% of acute coronary syndromes in women under the age of 50 are related to SCAD. More than 90% of SCAD cases occur in middle-aged women. Multiple studies have shown this across time, both prospective and retrospective. Prospective meaning after a SCAD event. And all races are affected, but Caucasians are the most highly affected, accounting for more than 80% of cases. This is a Vancouver group of about 330 patients, again showing sort of the age distribution of SCAD presentations, with the average age being around 52 and 90% of patients being under the age of 65. There are many conditions that are found to be associated with SCAD, either happening concurrently or potentially predisposing to. And this has consistently been shown across studies. And with fibromuscular dysplasia, hormone-related states, whether it's pregnancy or exogenous hormones, connective tissue disorders, systemic inflammatory diseases. The table on the right is from a recent study, which prospectively looked at patients after a SCAD event and sort of confirmed what had been seen when examined retrospectively in a number of studies, as shown in the scientific statement from the AHA on the left. So we'll go through some of these conditions. So fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory vascular disease that can affect nearly any arterial bed. It's characterized by dysplasia, disorganization, and or destruction of the smooth muscle cells, the fibroblasts, the connective tissue matrix, resulting in weakening of any of the three arterial wall layers and making them prone to dissection and aneurysm. And FMD predominantly affects women. It can manifest as stenosis, aneurysm, tortuosity, or dissection. And multifocal FMD is the most common. That's the alternating stenosis and dilation that's classically described as the string of beads appearance that you learn about. Focal FMD is characterized by a single concentric or tubular narrowing, but accounts for fewer than 10% of or is seen in fewer than 10% of FMD cases. And of the dissections that are seen in FMD, 10% of them are attributed to SCAD. There's a very high prevalence of concomitant extracoronary FMD in SCAD patients. So once we've identified a patient as having SCAD, they get screened for FMD, and a very high prevalence or high percentage of patients have concomitant extracoronary involvement. And that prevalence varies depending on how you screen for them. So invasive screening up to 80% of patients, 50% at CTA, and 25% with MRA. And the difference in resolution sort of accounts for these differences. The most common extracoronary beds involved in SCAD patients are renal, cervicocephalic, and iliac. Here's just some imaging to demonstrate this classic string of beads or multifocal FMD in the renal arteries with different modalities to show them. You can see the alternating stenosis and dilation. And usually it's very septated. So if we were to try to put a wire in and balloon it, you're not necessarily trying to create a smooth lumen so much as break the septations that are within the lumen of the renal arteries. So what classifies or what describes coronary FMD? 100% of patients or coronary FMD cases will have tortuosity of their coronaries. More than 50% will have dilation or ectasia. There can be smooth or irregular stenoses in the vessels. And we'll look at some pictures of each of these. So as I said, 100% of coronary FMD is characterized by tortuous vessels. And this can range from mild 180-degree bends as seen on the left, or severe with 360-degree loops in the blood vessels. Again, sort of getting back to torsion and altered flow as they go through these bends. Coronary dilation or ectasia can be seen in about 50% of coronary FMD. Dilation is sort of a more subtle form, which is seen on the left, and on the right, ectasia, which by definition is sort of an enlargement of the blood vessel to more than 1.5 times its normal size, usually involving at least 1/3 of the blood vessel. Irregular or smooth stenoses can be seen in coronary FMD. You can see how this would be very difficult to identify as, oh, I saw this and I'm pretty sure my patient has coronary FMD, because when you look at it, it just looks like mild atherosclerotic disease, and certainly it could be and would require additional imaging to really determine what's going on in there. What about hormone-related things? So lots of changes happen in pregnancy. The high level of progesterone weakens the arterial media. High level of estrogen results in the release of matrix metalloproteases that decrease exovascular structural support and also create a hypercoagulable state. And it's suggested that the weakened walls, in combination with the prothrombotic state, increase the risk of vessel dissection, false lumen formation, and subsequent thrombosis. In addition, during pregnancy, there's increased red blood cell mass and plasma volume. The plasma volume actually increases by 30 to 50% by the end of pregnancy, and cardiac output increases to 6 to 7 liters during the second trimester and up to 10 to 11 liters per minute during labor. And the increased shear stress during labor creates microstructural changes to the aorta, which can extend to the coronaries. So pretty consistently across many studies, we've seen an association between SCAD and pregnancy or exogenous hormone use, with pregnancy-related SCAD accounting for 8 to 10% or in patients, and 10 to 12 hormone-related. And the more repetitive the insult, meaning multiple pregnancies or carrying multiple fetuses at once, or longer duration on hormone therapy, they all have a similar mechanism of weakening the blood vessels and making them prone to dissection. This was a Mayo series of 54 patients with pregnancy-associated SCAD. The vast majority, more than 70%, occur within the first month following delivery, with the majority of those, more than 50%, occurring within the first week. And the study suggests that the phenotype of SCAD associated with pregnancy is a very severe one, more often presenting with STEMI, reduced LV function, left main involvement, or multi-vessel involvement. So this might be possibly related because they're older at the time of first childbirth, or they've had more pregnancies, therefore more time for their arteries to weaken. And interestingly, pregnancy-related SCAD patients have fewer extracoronary vascular abnormalities. As I mentioned, lots of connective tissue disorders and systemic inflammatory conditions have been identified sort of after the fact in patients who present with SCAD. The connective tissue disorders, about 5% of patients end up with SCAD are found to have a connective tissue disorder, either known beforehand or diagnosed afterwards. And about 8 to 10% of SCAD patients have systemic inflammatory conditions. And it's felt that they're at risk just because chronic inflammation of the vessels weakens the layers of the vessel walls. Many emotional and physical stressors have been identified. Again, consistent across many studies when patients are sort of probed and asked for, what was going on prior to their admission to try to look for anything that could have precipitated the event. Emotional stress patients are often, they report either a high or severe ongoing major stress prior to their hospitalization. Physical stress is usually sort of qualified as sort of new or unusually physical activity, unusually intense physical activity within 1 week of hospitalization for their SCAD event, or intense isometric activities like lifting more than 50 pounds. Intense Valsalva-like activities such as retching, vomiting, cough, labor and delivery, as we said before, can certainly be the cause. And perhaps not surprisingly, men more often cite a physical stressor like exercise or heavy lifting rather than an emotional stressor. So how do these patients present? Remarkably similar to how patients present with atherosclerotic MI. They present with chest pain. It often radiates to the arm or to the neck. They have diaphoresis, dyspnea, nausea, vomiting. Sometimes they even present with VT, VF, syncope, sudden cardiac death, things like that. So the most striking difference between SCAD MI and atherosclerotic MI is the type of patient. So it's really important to keep a high index of suspicion when you're approaching these cases. As I mentioned in the very first slide, by definition, SCAD is creating or causing a myocardial infarction. So they all have acute coronary syndrome. They all have elevated cardiac enzymes by definition. Sometimes they present with STEMI, but more commonly with NSTEMI, usually across the studies, approaching 3/4 of patients are presenting with an NSTEMI. And interestingly, only 20 to 30% of patients have an EF that's less than 50% during their index hospitalization. Their enzymes generally peak lower than an atherosclerotic MI, and they have relatively preserved LV function, as I mentioned, perhaps reflecting the fact that there's either less myocardium at risk in a SCAD MI, because it does often involve more distal vessels, or perhaps a reflection of the fact that in general, it's a healthier population. It's younger people with fewer traditional risk factors for MI, and so that may account for the sort of less damage done. In terms of coronary involvement, again, this is pretty consistent across studies. SCAD most often involves mid to distal segments, and as more often than not is a single vessel. Only 10 to 20% of SCAD cases involve multiple coronary arteries at once. And again, consistent is that the most commonly involved vessel is the LAD, or its branches, accounting for 40 to 50% of cases, followed by the circumflex and its branches, accounting for about 1/3 of cases. The RCA and its branches somewhere in the 10 to 20 or 30% of cases, with the left main being the least frequently involved, usually less than 5%, or about most of the studies say fewer than 5% of patients presenting with SCAD have left main involvement. So in terms of classifying SCAD, there are 3 main types of SCAD that we look at angiographically. Type 1 is the easiest. It's the one that looks like a classic dissection. It has multiple radiolucent lumens. You'll see usually sort of like a spiral dissection in the vessel. Type 2 is characterized by long, diffuse, and smooth narrowings in the vessel. And type 3 can be very hard to identify and looks like a focal or tubular stenosis, which could easily be confused with atherosclerosis. So we'll go through some examples of these. So type 1, as I mentioned, looks like a classic dissection. You'll have contrast staining. You'll sometimes see the radiolucent lumen or a ribbon sort of wrapping around the vessel. And here's some patient images. So in the right coronary artery, in both views, you see the type 1 dissection, and the one on the left is a little bit more clear. You can see sort of the radiolucent line that's sort of traveling around. You see it at different locations in the vessel in the main right coronary. The image on the right is not quite as obvious in terms of the white stripe down the middle, but you can see the irregularity and some of the lucency sort of in the distal bend of the right coronary artery. So this is your classic type 1 SCAD. Type 2 is characterized by diffuse stenosis, usually longer than 20 millimeters, and characterized by abrupt changes in vessel caliber. So type 2A specifically is the area involved is bordered by normal artery proximally and distally to the vessel. So you can see in this image, you've got a normal vessel, and then all of a sudden it becomes sort of diffusely diseased all the way down, and then abruptly it goes back to being a normal vessel. That's type 2A SCAD. And here are some examples of that. So in the image on the left, you have pretty normal LAD coming all the way down. abruptly towards the bottom, it develops stenosis, which then abruptly goes back to a pretty normal looking coronary in the apical LAD. Same thing in this right coronary artery. The vast majority of the vessel looks very smooth, very nice, no significant stenosis. Abruptly in the PDA, it changes, has a sort of a long area of narrowing, and then abruptly it changes back to a normal vessel to go out to the apex. So this is classic type 2A SCAD. Type 2B, same characteristics with the long diffuse stenosis, abrupt changes in caliber vessel, but in this case, it never returns to normal. The narrowing extends to the distal edge of the vessel. This can often be mistaken as normal vessel tapering or branch vessel disease, but it's usually evidenced by it's demarcated by an abrupt change from normal to abnormal. And if you have imaging, whether it be a ventriculogram or an echo or an MRI that shows a wall motion abnormality that corresponds, that helps you sort of say, okay, maybe that's not just normal vessel tapering, maybe that actually was SCAD involvement. So again, here are some examples of this. On the left, the LAD looks pretty normal, but the diagonal goes out and then abruptly changes into this sort of what we would call ratty looking vessel, and that extends all the way out to the distal edge of the vessel. Same thing in the image on the right. The OM looks very normal until all of a sudden it doesn't, and extending all the way out to the distal OM, it never goes back to full caliber of the vessel. Both of these patients were deemed on their cath to have luminal irregularities, or as I said, small branch vessel disease. So again, high index of suspicion, patients presenting with myocardial infarction, perhaps their gender or age could help. They may have a precipitating factor or an event, things like that. So definitely keeping a high index of suspicion to know what we're dealing with. And additional imaging can help to determine if you've missed something, or if you're suspicious but not certain. Perhaps the hardest one to identify is type 3, which is characterized by focal or tubular stenosis, usually more than 20 millimeters, that looks like atherosclerosis. So this one can be really difficult because this could just be mild disease that's not obstructive, but not anything concerning as well. So it really requires intravascular coronary imaging to show either intramural hematoma or intimal rupture, intimal tear. So here are two patients that were found to have, actually this is the same patient, type 3 SCAD. This was a woman presenting with an MI 2 days after starting chemotherapy. And very underwhelming coronaries. They are tortuous. Remember, we said tortuosity is very prevalent in SCAD. But the LAD, the left main, looked pretty normal, and then just kind of a little funny looking coming around these couple of bends and then back to pretty normal. Again, in the right context, if you looked at this in an outpatient coming in, you wouldn't think twice about it. Non-obstructive coronary disease, nothing to do. But in this case, she did have intravascular imaging and she did have intramural hematoma. So the diagnosis of type 3 SCAD was made. So type 1 SCAD accounts for about a third of presentations. Type 2 is the most common, accounting for 60 to 70%. And type 3, thankfully, is the least common since it's the hardest to identify. It's really important to recognize type 2 because it is the most common, but it is also the most frequently missed. So patients coming in, even though they're young and you may not be totally suspicious for a type 1 MI, you should cath them. If they have the classic type 1 appearance, you're done. You can make your diagnosis. If not, you could give some nitro because it could be spasm. And then you could consider intracoronary imaging or potentially to repeat angiogram in a few weeks, or you could just treat presumptively. And if it's type 3, you really need the intracoronary imaging to make the diagnosis. So let's go through some of this imaging. So as I mentioned, to diagnose SCAD, you have to have intramural hematoma or a double lumen or intimal tear. So with IVUS on the left, you see the classic white, black, white appearance of the intimal medial membrane separated by dissection, and then intramural hematoma behind it. But without that classic appearance, it can be very difficult to distinguish SCAD, which is in panel B, from atherosclerotic plaque, which is in panel C. So IVUS, when it's definitive, is very convincing, but it can be very confusing as well. So most people prefer to use intracoronary imaging with OCT because it gives you a much clearer picture of what's going on. And in panel A, you can see both the intimal tear as well as the intramural hematoma. And in panel B, it's just an intramural hematoma by itself. This does not look anything like, I guess I should have put a picture of what just atherosclerosis looks like in OCT, but it is very different than this and does not have this sort of hematoma, sort of bright to dark picture as the SCAD pictures do. What about non-invasive imaging? So CTA certainly can visualize dissection flaps, stenosis, and intramural hematoma, but intramural hematoma can mimic motion artifact. Non-calcified atherosclerotic plaque can be mistaken for intramural hematoma, and the spatial resolution limits visualization of the small and distal vessels. And as I mentioned before, SCAD most often affects smaller and non-proximal arteries. So CTA really won't see this well. It can be an alternative for angiography to assess for healing after a SCAD diagnosis that involved larger or more proximal vessels. And a negative coronary CTA does not fully exclude SCAD. What about MRI? So it's really not used for the primary diagnosis of SCAD, but it can be very helpful when the diagnosis is uncertain. So in the angiogram, you see a sort of distal LAD, not a classic dissection, but definitely a change in caliber, doesn't look completely normal. If it's a patient coming in with an MI, maybe you get a cardiac MRI to help you determine what's going on. And in this case, the delayed gadolinium enhancement shows up in the distal LAD territory, and there's also evidence of myocardial edema in the LAD territory. So it can be very helpful when the diagnosis is uncertain, but you're suspicious. And here now you've confirmed that there's been an infarct in the area supplied by the area of concern. That can help you make your diagnosis. Okay, moving on to treatment. So most SCAD arteries will heal spontaneously. The resorption of the intramural hematoma begins within days with complete angiographic resolution in most cases, almost 100% within 4 to 6 weeks. And in fact, some studies have shown 100% resolution when patients are re-imaged after 35 days. So because of this, conservative management is recommended in most patients. And dissection extension requiring in-hospital revascularization occurs in only about 3% of patients. So you can feel pretty safe with a conservative management strategy once you've made your diagnosis. This is a study that looked at 64 patients with acute coronary syndrome related to SCAD, the majority of whom were treated with medical therapy. Repeat angiogram was performed in about half of the medically managed patients, and all but one showed completely healed dissection and patent affected vessel. So this is one of our patients. On the image on the left is at her index hospitalization with SCAD. You can see the distal LAD has type 2A SCAD. She continued to have persistent pain over the following months. And so she was recath a few months later just to see if there was something else going on. And you can see that that affected segment in the distal LAD is now completely normal without any intervention. This was a study looking at patients who were revascularized or not. And you could see that in the group that was revascularized, that 28% of patients had either recurrence in the originally affected vessel or extension of the original dissection in that vessel, whereas those who were managed conservatively did not have any recurrence or extension of that dissection. So if it can be managed conservatively, it should be managed conservatively. This is a more recent study just from last year with 750 patients diagnosed with SCAD who were followed prospectively for 3 years afterwards. And you can see that there was no benefit to revascularization, either in terms of in-hospital events or 3-year follow-up events, death, MI, recurrent SCAD. But there was some harm. There were more adverse events in the patients who underwent PCI in hospital. Now that didn't persist at 3 years, but there is can be some harm to fixing and really not a huge benefit to. So if you don't have to do anything, don't do it. Sometimes we're forced. So when are we forced? So it should be considered if there's ongoing or recurrent ischemia. And you should note that chest pain does not necessarily mean ongoing ischemia. This pain has a similar mechanism to pain in aortic dissection. It hurts to have the layers of the arterial wall separate. So ongoing ischemia, not ongoing chest pain. Hemodynamic or electrical instability, left main dissection, or severely limited flow like a STEMI would warrant revascularization. So if there are no high-risk features, conservative management. If there are high-risk features, they get revascularized, preferably PCI, because it's hard to put someone through bypass surgery for something that theoretically is going to heal itself, but sometimes it is necessary. PCI is successful or partially successful in only about 50 to 70% of cases, which is pretty abysmal for what we do compared to our traditional coronary revascularization. 10% will require urgent CABG and 5% will have stent thrombosis. The issues that we face are that the vessels are already architecturally weak from the underlying arteriopathy, so they are prone to dissection, which we can extend with a wire, a catheter, an imaging modality. It can be difficult to get your wire into the true lumen instead of the false lumen, depending on where the dissection starts. Inflating balloons or stents can propagate the intramural hematoma distally or proximally, further compromising the lumen. We have ways to get around this. We use longer stents, extending 5 to 10 millimeters distally and proximally to where the dissection or intramural hematoma is noted. And then often we'll stent the edges of the vessel of the affected area before we stent the center of it. But again, now you're committing a patient to much longer areas of stent, which is higher risk for in-stent restenosis. And finally, while the stents may be appropriately sized at the time of insertion, the hematoma will eventually resorb, resulting in stent malapposition and increased risk of stent thrombosis. So here's a case, a patient with proximal LAD disease, which was not initially recognized to be SCAD. It was ballooned. And you can see in the center angiogram that the flow down the vessel is no longer normal. It takes a long time to get to the apex. And then that was subsequently treated with a stent. And you can see that while the stented area looks good, there is now a new lesion, sort of a little bit distal right here, right where that circumflex crosses it. Again, because we sort of toothpasted out the intramural hematoma further down the vessel. So now that patient needed an additional stent. And in the end, they had a very nice result. But now you have a patient with 2 stents in their proximal LAD that might not have been needed in the first place. When percutaneous revascularization is needed, it can be done safely. This is data published in JACC Interventions last week, actually, showing similar in-hospital mortality and 30-day readmission for patients undergoing primary PCI for STEMI in SCAD versus non-SCAD STEMIs. So it can be done safely when it is needed, but it should not be done unless it is absolutely needed. Surgical revascularization is considered when there's left main dissection or extensive dissection involving the proximal arteries, if PCI has failed, or if it's anatomically unsuitable for PCI. But the long-term graft patency is only about 25%, and that's because there's spontaneous healing of the vessel, which is going to result in competitive flow and ultimately graft thrombosis. So it can be a very important temporizing strategy, but it's a lot to put someone through for something that's not going to give a long-lasting benefit. In terms of treating our patients after our SCAD diagnosis, aspirin is definitely recommended. This is based on data in acute coronary syndromes in general and secondary prevention and the fact that it has a low side effect profile. Beta blockers are known to decrease arterial shear stress. This is based on data from aortic dissection. So they should be used acutely and long-term. And beta blockers have even been associated with a decreased risk of SCAD recurrence, which I'll show you some data on in a second. In terms of Plavix, I mean, definitely if the patient's undergone PCI, they should be on it. If not, it's a little debated. Certainly there's the prothrombotic nature of intimal tears. There's the potential decreased false lumen thrombus burden and therefore decreased true lumen compression. But at the same time, it's a blood thinner, so it could extend the dissection or the hematoma. So sort of the jury's still out and it's operator preference or provider preference. My general practice is not to continue Plavix in these patients. Statins, angiotensin, receptor blockers or ACE inhibitors. Really, if they have another indication for those kinds of things, definitely use it. But in SCAD specifically, there's no additional benefit to being on those things. So if they have hyperlipidemia, yes, they should be on a statin. If they don't, then not necessarily. In terms of thrombolytics and 2B3A inhibitors, they are contraindicated because they can extend the intramural hematoma in the dissection, and they have higher bleeding risks. Heparin, sort of same thing. It can extend the dissection, but it could resolve the overlying thrombus and improve true lumen patency. Generally, the recommendation is to stop heparin once your SCAD diagnosis is made. So this is that contemporary data, the prospective study that followed patients 3 years after SCAD, showing that most patients are on aspirin, more than 90%, and they persist on it. Same thing with beta blockers, somewhere in that 80% range. And then with variable use of P2Y12 inhibitors, statins, et cetera. After diagnosis, patients should follow, if you have vascular medicine, they should follow with them. At the very least, they should be screened for fibromuscular dysplasia or other connective tissue disorders. They should have vascular imaging from the brain to the pelvis. And the head and neck CTA, specifically to look for cerebrovascular FMD, is important. Because 15 to 25% of SCAD patients will have cerebrovascular FMD or intracranial aneurysms. Renal and iliac angiography during cath was, more often done when we did femoral cath. Now that we're radial, that's not as commonly used. Certainly abdominal CTA can be used instead of the invasive angiography, but it is less sensitive. But really any kind of imaging, just definitely looking brain to pelvis for involvement of FMD. And then close cardiology follow-up to monitor for recurrence, but also because patients have a lot of symptoms afterwards. 20% of SCAD patients are readmitted within 30 days. Their ongoing pain is suspected related to microvascular dysfunction. Going down the line, acutely still may be related to just the dissection itself. Again, the tear being uncomfortable. They're usually nitrate or calcium channel responsive if it is microvascular. And this is, again, that same study showing that 40 to 50% of patients have chest pain, be it typical or atypical, in the first year. And that starts to decline, but it is still 30% at 3 years. And in fact, 20% of patients are present to the ER with these chest pains, 7% admitted, and as I said, 30% still having chest pain at the 3-year mark. So definitely cardiology follow-up to help guide treatment, further imaging if needed, additional angiogram if needed for confirmation of resolution in case maybe with the wrong diagnosis, things like that. SCAD can recur, and there are many factors that are possibly associated with SCAD recurrence. That's all these things on the left. Some studies are showing associations with these things, emotional stress, hypertension, hormones, et cetera, with hazard ratios as high as 3 to 5, but they're not consistent across studies. So we're not really entirely certain what predisposes to or protects against recurrence. What we do know is that recurrent SCAD usually involves anatomic sites that are different from the original SCAD lesion. They usually present months to years after the index event, and they can recur multiple times. This is older data that suggested a 10-year recurrence rate at 3 years and 30% recurrence at 10 years. But this was all based on retrospective data again. It also showed that there are more recurrences in the hypertensive population. This is possibly related to vessel tortuosity because we do see significant coronary tortuosity in patients with hypertension. And fewer recurrences in patients treated with beta blocker. Again, this is why we recommend part of the reason that we recommend beta blocker in the SCAD population, with a hazard ratio of 0.39. This is more recent data, again, from the study that followed patients prospectively 3 years after their event. And overall MACE was at 3 years was 14%, but over half of that occurred in the first 14 days. Afterward, there's really not a huge increase in events. And recurrent MI was about 10% over 3 years, but extension of SCAD or de novo SCAD was only about 3%. So it seems like the recurrence rate was not quite as high as originally thought, which was originally thought to be 10% at 3 years. It's more like 3% at 3 years. After discharge, patients should be counseled to avoid heavy lifting, no more than 20 pounds for women, 50 pounds for men. Women should avoid future pregnancy. Men and women should avoid hormonal therapy. And cardiac rehab is recommended with a low target heart rate and blood pressure. Cardiac rehab has consistently been shown to be safe in patients with SCAD, and it results in improved exercise capacity, symptoms, particularly chest pain, and psychosocial well-being. There's a Mayo registry in which 82% of SCAD patients who did cardiac rehab reported physical health benefit and 75% reporting emotional health benefit. Their target heart rate during cardiac rehab should be 50 to 70% of their heart rate reserve, which is based on initial stress testing. They should start with 3 times per week for 20 to 30 minutes. It should be a conservative program without high intensity interval training. And their long-term goal is to be able to exercise 45 to 60 minutes most days of the week. There are psychological effects of SCAD, and this study showed that SCAD predicted anxiety, depression, and distress, both cardiac and just general, after controlling for female sex, younger age, and other confounding variables. So we're not just saying, oh, well, this is a young person who had an MI, obviously they're going to have some psychosocial effects. They controlled for that, and still SCAD predicted these negative psychosocial effects. So psychosocial support should be an important component of cardiac rehab in these patients. So for take-home points, SCAD is more common than you think. It is more common in young women. It presents with the classic symptoms of MI and with positive biomarkers. Angiographic findings can vary and can be subtle. Conservative management is recommended most of the time because it spontaneously heals and has a low incidence of recurrence. Long-term aspirin and beta blockers are definitely recommended, and they should have low intensity cardiac rehab and be screened for FMD. So while SCAD is so often confused for another diagnosis, or sometimes called mild atherosclerotic disease, it is actually spontaneous coronary artery dissection, and we should not be missing it. And that's all I have. Luckily, these guys all stayed quiet today for this talk. And that's all I have.
Barbara, fantastic talk. You wouldn't get a presentation like this high quality, even at ACC national meeting. Congratulations for putting all this together, and great thoughts. In terms of patients that may have one of your risk factors, or FMD, but haven't had a spontaneous coronary artery dissection, did you find anything in your reading as to what a patient may be counseled to do to avoid dissection? And then question number 2, once the individual has sustained a spontaneous coronary artery dissection, and you certainly have outlined cardiac rehab and the medical therapies, do they follow with someone like yourself with a interventional cardiovascular medicine background, or who would you recommend would follow that patient, and how would a primary care physician be counseled to manage the patient, because they obviously will be seeing them for general health considerations?
Yeah, so for FMD, the main focus of prevention is vascular health, which, easier said than done. But the biggest thing that we can do is blood pressure management. So blood pressure goal for these patients should be less than 120/80. So I know that's what the guidelines say is normal, but more often than not, we're happily settling for 130s/80s, with our realistic life population. But with patients who have been diagnosed with FMD, we really have a very, very aggressive blood pressure goal for them of less than 120/80, because that's sort of the only thing that we can actually do that will minimize the risk. What's, the arterial weakness is the arterial weakness. There's nothing we can do to change that I've seen. So really just aggressive blood pressure management. And then, avoiding the things that we know can further weaken or stress those vessels, like heavy isometric exercises, hormone therapy, pregnancy, things like that. In terms of follow-up afterwards, I don't think they necessarily need the interventional side. Again, the vast majority of people should not be intervened upon. I find that many of the patients, and I do follow a number of them, but that many patients do well with someone who, with a focus on sort of like the women's cardiovascular stuff. Like when Phoebe was here, she saw a lot of them. Alexa Ward down at Riverside sees a lot, things like that, sort of focusing on the sort of non-modifiable risk and things like that, but also sort of that gentle, guiding hand. But really, I think anybody in cardiology can do it, as long as they have an understanding of, what they're dealing with. And then primary care, I think, the education there is sort of knowing that not all chest pain, that it's common for them to have chest pain afterwards, and obviously cardiology will manage what to do about it, but, the psychosocial, psychological effects, I think helpful, plus the blood pressure and sort of lifestyle changes and things like that. But again, I don't think there's any, obvious, if we did this, then we would avoid that kind of thing to have either telling our patients or the primary care doctors, unfortunately.
Thanks so much. Great job, Barbara.
Thank you.
Great talk, Dr. Lawson. Thank you so much. I really learn so much from you every time you teach. I have a question about intracoronary imaging. I know you mentioned briefly about how OCT can be a little better compared to IVUS, just based on the technologies. Would you advocate for routine intracoronary imaging, especially like in type 2 and type 3 SCAD, when it's not clear cut, but you see a dissection flap or contrast hanging up? Are there any caveats for that, or is there any risk of overdiagnosis of SCAD without intracoronary imaging? Can you elaborate a little bit on that?
Yeah, I think that's a great question. I think my plug would be for type 2 that we should just be able to recognize it. I do think it's a very classic appearance. It's just having the education and the knowledge to identify it. Type 3, obviously much harder because we really don't know. So some of it is index of suspicion, the right patient population, things like that. You could certainly make an argument for intravascular imaging for every single one of those patients. I think I would advocate for the non-invasive side of things, where if you see something that's like, wow, that's a little funny looking, it's kind of the right population, I'm suspicious for type 3 SCAD, then going the next step and getting the cardiac MRI to look for, well, is there an infarct that correlates, or is it myocardial edema that correlates with that lesion that would then help you say, okay, yeah, I think that's what that was, right? If you see a mild atherosclerotic plaque like that, and there's not an infarct there, then, that's probably not SCAD. But if there is an infarct there and it's not something that you see and you're like, yeah, I'm going to stent that, then it's probably SCAD. So I think there are places that routinely do the imaging, but I think the vast majority of the time, certainly in type 1, should be. In type 2, you don't need it. In type 3, I think you could push for either a non-invasive or an invasive management strategy there.
Sounds good. Thank you. We have a couple of questions in the chat. Dr. Vizar says, great talk. Thank you. Do you use LV motion by echo to consider PCI in these patients with CAD despite hemodynamic stability and no recurrent angina? Or will they recover wall motion abnormality despite the lack of intervention?
They should recover wall motion abnormality. And as I mentioned, the vast majority don't have a low EF. So while they may have wall motion, they're not actually losing enough motion to drop their ejection fraction. So the majority of them will recover. It is an infarct, but it's a small infarct, and majority of the time. So the people who are asymptomatic and hemodynamically stable generally are not going to sustain any long-term hemodynamic or functional changes in their echo.
Sounds good. I see Aaron Schatz raise his hand. Aaron, do you want to go ahead?
Yeah, thank you. Appreciate it. Barbara, fantastic talk. With the role of CTA now, kind of being more heavily utilized, are there institutions that are sending this high index of suspicion population with maybe lower troponins and no active chest discomfort at the time to get a CTA prior to invasive angiography?
I don't think so. I don't know if there could be places, I suppose, that are doing it, but again, it's really difficult to use CT for diagnosis because, soft plaque can look like intramural hematoma, right? So they're going to have, I am by no means a non-invasive imager, so please don't, put all of your stock in me on this, but there could be very similar appearances. So I don't think you're necessarily going to say one versus the other in those circumstances. And also because SCAD so often involves the distal vessels, which angio is going to have a harder time seeing. CT angio is going to have a harder time seeing. So I think, again, it can be useful in follow-up if you had proximal vessel, large vessel involvement, but less so in diagnosis because a negative CTA does not necessarily rule it out.
Excellent. Thank you so much.
Yeah.
Our next question is from Tishik Park. He asks, what about utilizing nitroglycerin infusion compared to blood pressure control only, since it's working on coronary vasodilation more directly rather than blood pressure itself? Any more benefit or harm? Any difference in efficacy in between, or still needs to focus on BP control? I guess this question is more about whether using nitroglycerin oral vasodilators compared to other blood pressure medicines for.
I think if your patient's having angina and you're not just treating blood pressure, then nitroglycerin makes sense, especially as I mentioned, a lot of them do have chronic angina after their SCAD event. Whether we don't know for certain that mechanism, but it is postulated to be microvascular dysfunction, in which case nitroglycerin could help. So I think that certainly, if you're going to choose agents that have an effect on blood pressure and potentially treat chest pain, just like we do in our regular angina population, that works. But I think in terms of just protecting your blood vessels from, recurrent events, it's mostly just decreasing the stress on them. So that's just any means of blood pressure control really will be effective.
Good. I didn't see any more questions. If anybody has any more questions, please email them to me or Shannon Winston. Thank you so much, Dr. Lawson. Once again, appreciate you. Appreciate all that you do.
Very good. Thank you, guys.
Thank you.